what's the role and capacity of the collective to take care of people at the margins? Jim Frankish. I'm a full professor in the School of Population and Public Health. Do research mostly on homelessness, but I've done pretty much every topic imaginable.
My name is Jean Shoveler. I'm a researcher at the School of Population and Public Health at the University of British Columbia. My research focuses on social health inequalities, especially social health inequalities experienced by young people.
My name is Paul Kershaw. I'm a professor at the University of BC School of Population and Public Health, where I'm also the Associate Director of the Human Early Learning Partnership and the founder of Generation Squeeze.
As a researcher, the question I was interested in was that we have all these determinants of health: income, education, housing, gender, social support. They're much more important in terms of health of population than the healthcare system.
Because one of the things we've learned from the social determinants of health research is that human beings, as a species, we are especially sensitive to our environments when we're very young. And when you see this income down despite more education and facing higher housing costs, you're talking about a group of people who end up squeezed for time, money, and services. And that squeeze is felt by people as young adults, but they also happen to be in their prime childbearing years, and we're finding that the squeeze on young adults is also being picked up in terms of how their kids that they're having are doing when they start our school system. Starting off in ways that we wouldn't like them to, then they're more likely to fail in school, more likely to end up in jail, and more likely to end up sick as adults, all of which isn't good for those individuals and certainly more costly for society.
And these are all things that at a social or societal or collective level we can have a very important impact on.
People who have challenges, people with personality difficulties, with mental health issues, with head injuries, generally people who have trouble establishing and maintaining relationships with other people, they tend to drift downwards in society. They have trouble maintaining employment, maintaining education, maintaining relationships with their family. So you start off with a problem and you drift downwards. If you grow up in a poor neighborhood with high stress, and high violence, high crime, bad housing, the evidence actually suggests that in your 30s and 40s, 50s, you're more likely to get cancer, heart disease, diabetes. So things that happened 30 years earlier end up having a negative impact on your health because of the cumulative effect of constant stress. It's like running a car non-stop, 24 hours a day for 40 years. Eventually the motor gives out.
And I tend to think about high-risk populations really as a shorthand term for helping us think through kinds of social and structural and institutional arrangements that actually systematically disadvantage. I think, as Bob Evans has once said, it doesn't have to be this way.
How does your social context get under your skin? In other words, the getting under the skin is a process of embedding in the organism the social context as well as the physical context. If you're living in a toxic environment, that gets under your skin quite literally. You breathe it in or you drink it in the water supply, or that's really not all that good for you. The gradient then forces you to think about what is the social context of people at different steps in the gradient that pushes them towards or away from good behavior, bad behavior. How does behavior get embedded in the organism? In the same way, how does biology get embedded? I think it goes back to a misreading of Lalonde, although he's not around to defend himself. This lifestyle started off as a description of your social context, of how your life is lived. Mm-hmm. But it then became shifted towards making healthy or unhealthy choices, as if your lifestyle was something you chose, like chocolate or vanilla ice cream. It's not. It's the context within which you live your life.
Oftentimes when we think about interventions or things that we could do at the structural level, at the institutional level, we think that a one policy or a one legislative approach will be good for everyone. However, it may also be not so good for those people who live in the most risky contexts.
Oftentimes governments would say the cupboard is bare. We know early childhood matters, but there are no dollars in our public coffers that we can use right now to act on the evidence. Interestingly, you would have political parties on all sides of the ideological spectrum say that, and they would simultaneously, without question, find money for other important things, not least of which would be our healthcare system. And while that aspiration and our implementation of it shows a great deal of dignity to Canadians, it sometimes waits for people to become sick in the first place and then work really hard to treat their illness, rather than say, what can we do to prevent people from becoming sick at all?
I think the people who work in social determinants of health, the people who work in health generally, regard health arguments as trumping others. You can't do that. You're going to make people sick. You know, people will die because of what you're doing. Underlying that style of argument is the assumption that the people you're talking to actually give a damn. That you know, that's that wonderful quote from Homer Simpson. Just because I don't care doesn't mean that I don't understand.
For those approaches that are more individually focused, the notion is that we could actually do things or ask people to do things to change their behavior. But what we're really interested in is changing the world that people make those choices in. We're interested in changing the context. The social context, the physical context, the relational context, the institutional context that helps to shape anyone's and everyone's capacity to make choices about how they will live their lives. So we need to be looking at the things that are not working, and we need to be gathering evidence to show the kinds of laws or institutional arrangements that would actually promote and protect everyone's health, including those who are most at risk.
My approach to affecting change these days is really guided by the WHO Commission on the Social Determinants of Health. This international report from half a decade ago has asked public health scholars to think seriously about the role of our work influencing civil society to change the incentives to which our politicians respond. And that then creates possibilities for us to think about some knowledge mobilization campaigns, some community engagement activities in and of themselves functioning as population health interventions. And that's the sweet spot where I find myself these days trying to think about affecting change. How do we use the best information we have to drive the conversations that are happening publicly and the issues around which people are mobilizing, such that we create new opportunities for our best evidence to make its way into legislation, because politicians have new reasons to respond.
One of my colleagues, Rod Knight, asked me to consider an idea, and that idea was the notion of founding a summer leadership camp for young LGBTQ people from across British Columbia, to bring them together for 4 days of training, activities, fun, and learning and teaching one another and teaching us what it would take to change the kinds of social norms, the kinds of institutional policies, gender relations, power relations, what it would take to address rural and urban health inequalities that they were facing as LGBTQ youth, and how also to work with their families and friends and communities for the other 361 days of the year that they weren't at Camp Out. And so that, I think, is a great example of how we've put our research around what is it that young LGBTQ people are facing in terms of social health inequalities, and what can we, one of the things can we do to try to inspire social change in that area.
Certainly the largest, I would say the most important project, is a project called the At-Home Chez Soi project. It's the largest project of its kind in the world, and it's in 5 cities in Canada. It's a study of the impact of providing housing and support services to people with a history of homelessness. Second to last throne speech, the government announced $600 million to address homelessness based on the results of our project. And they cited the project as showing evidence that this approach works. And so it was strong academically, it was strong from a research perspective, it was strong from a social perspective, strong enough, I guess, from a political perspective that the government put $600 million towards combating homelessness. So they must have seen something that they thought fit with their agenda.
And people like you and I and the folks we work with get into this field because we think that health status, mortality, that these things really matter a lot to everybody, that we have a kind of a collective responsibility to worry about the health of the people around us.
And there's no doubt evidence is one factor, but it turns out it is one of many. And trying to figure a way that researchers can remain true to the objectivity of our scholarship and true to our need to go where the evidence takes us. After a while, though, we don't need to be so neutral about what the evidence tells us and what we should be doing with it. And I'm constantly trying to find the right balance between making sure society pays attention to our last great answer while simultaneously pursuing where the research leads in terms of answering the next great question.
Population health was and is important problems that are fundamentally complex and interesting and important to people. And I got paid to think about them and work on them with very interesting people. That's what resonates with me about population health. It's great.
Earlier this year, Louise Potvin, the editor of the Canadian Journal of Public Health, issued a challenge to population health researchers and public health advocates across the country and around the globe to not become obsessed with the mundane, to not accept that what we've done or achieved so far is enough, and to take risks and to take intelligent steps forward to really try to realize the goals and aims set out by Michael Marmot and many others with respect to realizing that the social determinants of health are absolutely fundamental to making for a healthy, productive, fair world for everyone.
You asked me earlier why I got into this. For me, love is the first part. The second is curiosity. And the third is just, I guess, at my core, my personal background, that it hurts me to see people suffering. But those three things, longing for love, thirst for knowledge, and concern for the suffering of people. And that's what makes it worth getting up and doing what you do.